So, hello everyone, and welcome back to another Rafael Medina subspecialty virtual morning report. Today, our focus will be on nephrology, and for this, we have two amazing case discussants and one amazing case presenter. As a case discussant, we have Dr. Matthew Sparks, who is an associate professor of medicine at Duke University and serves as a program director for the Nephrology Fellowship. He is a co-creator of Neph Madness, faculty lead of Renal Fellow Network, and an advisory board member of NephSim. And as another case discussant, we have Dr. Alessandra Tomasi, who is a nephrology fellow at Duke University. She completed her internal medicine residency at Mayo Clinic in Rochester and completed a chief residency year at Mayo Clinic this past year prior to starting her nephrology fellowship at Duke. And as a case presenter, we have Dr. Jahaida Jimenez, who is currently a PGY-free internal medicine resident at Duke University and just matched for nephrology fellowship at Baylor College of Medicine. Congratulations for that, first of all. And before we jump into the case, I will lead the mic to the case discussants to tell us something about yourselves and also tell us why you chose nephrology.
Okay, I'm happy to go first. Hey everyone, I'm Allie. Thank you so much for that intro and thanks for having us here today. I'm originally from Chapel Hill, North Carolina, so I was really excited to come back to the Triangle area for my fellowship this year and absolutely loving it just 6 months in. Outside of work, I enjoy running, and at work, I love everything nephrology. I knew I was going to do nephrology since I was a fourth-year medical student. I think it's an amazing specialty where you really hold on to your internal medicine. You can practice anything from primary care to intensive care medicine and everything in between. And I've never met a nephrologist who doesn't absolutely love their job. So since I was a student, it drew me, and every rotation I did just reinforced that. And I'm very happy to be here.
Amazing. And Dr. Sparks?
Yeah, hi everyone. I'm Matt Sparks. I'm the program director at Duke University and very excited to be here. I've been involved in online education for, I don't know, maybe 15 years now. And I think that this is a great way to learn. I think I've always had the opinion that when a learner first learns something for the first time, it's the most pure and unbiased time when you can learn, and also the excitement of them teaching other people is just infectious. So that's something I've always really tried to maintain throughout my career. Why I chose nephrology, one, I think it's a group of patients that really need a physician to make decisions in their lives, and you can see the immediate impact. And that's always sort of the first and foremost thing about why I became a nephrologist. The next is the people in the field. People who choose nephrology really love the specialty and always working together to take care of patients. So it's an amazing specialty, and I can't wait to talk about this case that we have prepared for you.
Thank you so much. And Jahaida?
Hi, thanks for having us. I'm very excited for the case too. So I'm originally from Texas, and outside of work, I have a little puppy named Gala. She's a mini schnauzer, so we love hiking. I also like running and working out. I love getting on the Peloton anytime that I get. And why I chose nephrology, I'm very interested in health equity and health disparities. A lot of the patients that I was meeting in my continuity clinic had uncontrolled diabetes, uncontrolled hypertension, and those are the people that a lot of the times end up with CKD. So that was one of the reasons. The people, like Ali mentioned, every single nephrologist that I met is always so excited to teach you and so excited about the field, and it's just so contagious. And then the ability to take care of the patient in every single stage of their life was really something that I really, really loved about nephrology.
That's so impressive. First of all, thank you so much for being here with us and for teaching us nephrology. I'm so excited for the session. And Jahaida, whenever you feel ready with the first aliquot, I would ask Masa, who's going to scribe, to share the screen with us, please.
Awesome. All right.
Okay.
So we have a 50-year-old woman with past medical history of cirrhosis secondary to alcohol use and MASLD. And she is being brought in by her family for worsening abdominal distension and confusion for about a week. She is being admitted to medicine for decompensated cirrhosis and hepatic encephalopathy. And nephrology was consulted when her initial labs resulted with a creatinine of 1.6 and a sodium of 121 from a normal baseline a month prior.
All right, thank you. So I guess I can go ahead and get started here. So first things first, very common consult that we receive in nephrology. And so there's a couple things that run through my mind almost immediately. First of all, it sounds like we had normal, you said kidney function and normal sodium about a month ago. So something has happened in this either acute or subacute period in this young lady presenting with decompensated cirrhosis. And as soon as I get a consult for AKI and cirrhosis, one of the first things popping through my head is, could this be hepatorenal syndrome? And I think the reason that goes through my mind is, first of all, that changes management. And second of all, I think that's on everyone's mind, but that's something that we definitely shouldn't be anchoring on, and still need to do a full AKI workup. So immediate things that come through my head when I'm calling the primary team would be, what does this patient look like clinically? What are her vital signs? Is she hypotensive? Is she afebrile or febrile? Is she on room air? What's her respiratory status like? What's her volume status? And then would like to just hear a little bit more about her basic admission labs.
All right, so so first of all, her vitals. So she's hemodynamically stable. Her SBP when she presented was 95 to 105. She's historically in the 100s to 120s. Her heart rates were 70s to 80s. She's afebrile. She's sitting well on room air. On her physical exam, she's jaundiced. She has abdominal distension, 2+ pitting edema. Her lungs are clear. Her cardiac exam is normal. She's alert and oriented ×4. Her labs on admission show that sodium of 121 with a baseline normal a month prior. Her potassium is 4.4. Her bicarb is 18. Her BUN is 16. Creatinine 1.6. Her baseline is 0.7, and we have a baseline about a month prior to admission as well. Her CBC is remarkable for a hemoglobin of 8.9. We have labs from a week prior to admission that showed a hemoglobin of 11. Her platelets were 80, and that's her baseline. Her INR is 1.6. She has some slight transaminitis. Her AST is 86, ALT is 42, but that's about her baseline.
Okay, thanks. Lots to digest here. So bringing it back, if we have our one-liner, young woman with decompensated cirrhosis, maybe mildly hypotensive, has ascites on exam, and we are consulted for AKI and hyponatremia. So the first thing is, how can I tie these two together, right? Like, how do I tie in a low sodium with an elevated creatinine? And the first thing that I'm thinking about is she probably is in this physiologic state of decreased effective arterial blood volume. The kidneys are not seeing enough perfusion, and because of that, they're holding on to water. And there's probably some activation of some compensatory mechanisms that are leading to an elevated creatinine. So first things first, like, why is she decompensated? Why is she declining in her GFR? Does she have signs or symptoms to suggest infection? I mean, you told me that she's afebrile, but still want to know, could she be almost septic? Is she infected somewhere? I'm curious about that hemoglobin. You said it's 8.9 now, it was 11 a week ago. So why the drop? Is she bleeding? That's also really common in this patient population. So I'd ask her about signs and symptoms of an upper or lower GI bleed. And then I saw this pop up in the chat, 110% agree, acute kidney injury. What does your urine look like? I want that UA, I want that microscopy. I want them to tube me a sample so I can take a look at it myself. What is the urine sodium? What is the urine osmolality? That's helpful both for the AKI and the hyponatremia. And what is the serum osmolality? It's very common to see hyponatremia in these patients, but you always want to confirm it. So make sure that serum osm is low. And I think now is also probably a good time to mention, since this is something I learned during my fellowship actually, is in patients with cirrhosis, our cutoff for hyponatremia is a little bit lower than it is in other patients. It's actually sodium less than 130. We're not aiming for that normal range. So this is someone with definitely hyponatremia by any definition. It sounds like she's probably asymptomatic since you didn't mention anything acute there, and we have some time to work it up. But first things first, those questions about infection, the questions about bleed, and then her urine studies and serum osms. in her, young woman, I'm not immediately thinking obstruction, but she does have ascites, and this is someone who we're thinking about A through Z, what could be going on. So I think low-hanging fruit would also be to ask her about symptoms of urinary retention, get a bladder scan, and maybe just ultrasound her kidneys and make sure there isn't some obvious hydronephrosis.
Wow, those are great thoughts initially, and we did get all of that information for you. So we got the pristine UA like you asked. So the urine was bland. There weren't any casts there. There was no pyuria, no other symptoms, no other signs there. Her urine sodium was less than 10. Her urine osmolality was 298, and her serum osms were 266. We did ask her whether she was having any symptoms of bleeding. She didn't report any melena, no hematochezia. She wasn't having any hematemesis. She wasn't having any reported urinary retention either. She said she was urinating normally. The kidney ultrasound did not show any hydronephrosis, and we did obtain a bladder scan. It did not show any retention there. By this time, we got blood cultures back that were negative, so infection had been ruled out, at least from a bloodstream perspective, and she underwent therapeutic paracentesis, and it did not show any evidence of SVP. And then you did mention some concern for bleeding, and GI was actually consulted. And because of that hemoglobin drop, they did want to get an EGD, so she got that on hospital day 4. And it showed grade 1 esophageal varices, but no stigmata of recent bleeding.
Fantastic. Both of you are doing a great job. I want to add a few comments to the discussion. The first is the second thing I like to look at when you see a patient in this sort of scenario as a nephrology consultant is always starting to think about liver transplantation because that's really the ultimate goal for these patients. And so in order to do that, you first need to think about how to get a patient to the OR safely. And one of the barriers is hyponatremia. And so usually the goal for that is about 125. And so that's one aspect of the case that you want to at least be conscious about. The second one is about volume status. And this is a really tough one for physicians to really kind of grapple because we're actually not that good at volume status. I'm going to take us to a paper published in the American Journal of Nephrology by a good colleague and friend, Juan Carlos Velez, and did a pilot study of about 53 patients where all of them were deemed to have potential hepatorenal syndrome, and they all already had volume resuscitation. So they all thought they were euvolemic. And they did point of care ultrasound on these individuals, looking at IVC diameter and IVC collapsibility. There are still, better ways that you can do volume assessment like VEXAS, but they just chose those two, which I think is actually pretty good because most people can do those two. And what they found was very interesting. Of the 53 patients that were deemed to be euvolemic and volume resuscitated, 19, almost a half of the patients were found to be actually euvolemic. The rest of them either were volume down still, 15 patients out of the 53. 11 of them were found to be volume overloaded and needed to receive diuretics with resolution of their AKI in 30%. And then 8 patients actually had intra-abdominal hypertension, in which paracentesis actually improved the AKI at about 50% of patients. So one of the things that I like to at least do when I see a patient here is, yes, the physical exam is very important, but we have tools at our disposal to really go deeper into the volume assessment, which is a very important aspect of treatment for patients that have suspected hepatorenal syndrome.
Yeah, thanks for that. I'm curious if the team focused this patient in particular, but I struggle so much with my volume assessments in patients with cirrhosis because inevitably there's so much to interpret. There's peripheral edema, but then lungs are clear and you're looking for JVD and they have ascites, and it becomes challenging. And when we're thinking about resuscitating patients with cirrhosis, it's a day-by-day decision. It's not a one-size-fits-all by any means. So thanks for that extra input, Dr. Sparks. I guess we just got all of this information. I'm going to digest it quickly, but paracentesis, no SUP. Yeah, so it sounds like, again, decompensated cirrhosis. Why is she decompensated? Well, no signs of infection or sepsis. Thank you for the EGD. I'm glad it was done. No signs of bleed. And gosh, her urinalysis is so bland. I didn't hear anything. No granular cast to suggest acute tubular necrosis. You said her urine sodium was low, less than 10. So again, suggesting some intact tubules here. No pyuria to suggest infection or AIN. I forgot to ask, this should be one of the early questions, was any new or recent medication changes, either prescribed or over the counter, but nothing here, at least on urine sediment, to suggest an AIN picture. No hematuria, no cellular cast. You still want to be thinking about intrinsic renal injury here, right? Like these patients can still develop a GN. So nothing I'm seeing here that's tipping me in that direction. No hydro, no retention. I mean, really, really nothing here. And so again, going up to that, I guess, very first question that popped into my mind is, could this be hepatorenal syndrome? And at this point, I'm thinking, yeah, it really could be. It fits, right? We have that decreased effective arterial blood volume. That urine osm's a little bit borderline at 298, but it's still high. It's greater than 100. It's greater than the serum osmolality. So ADH is on. Our body is holding on to water. Our body is holding on to the sodium. We have our activation of our renin and angiotensin system. And so the reason I say hepatorenal fits is really because the physiology doesn't lie, right? And like we all love nephrology because we all love physiology. So I guess I could talk a little bit about HRS physiology and why I think it fits here. Ultimately, that buzzword we hear is the splanchnic vasodilation, right? And so we have increased portal pressure. Thank you, Dr. Sparks. We have increased portal pressure. We have decreased splanchnic pressure because we have splanchnic vasodilation. Lots of mechanisms for this, but one of the major ones is that we have decreased metabolism of vasodilators, nitric oxide, prostaglandins, et cetera. And so what happens is, the kidneys, they see less blood. There's decreased kidney perfusion pressure. And because of this, we have adaptive compensatory mechanisms kick in. You have your renin angiotensin system turn on. You have your sympathetic nervous system turn on. In patients who have cirrhosis but are not decompensated, cardiac output increases. And so on a day-by-day basis, your body is trying to make up for all this. But then something happens and you end up decompensated. And all of these compensatory mechanisms that are supposed to help end up hurting and they're maladaptive. And then you end up with this decline in GFR, your uptrend in creatinine, this worsening hyponatremia. And that's where we really, really, get in trouble. And so I think that's what's going on here. We've gotten a pretty good workup of this acute kidney injury and the hyponatremia. I know that, a common question I get from learners who are on service with me is about HRS and definitions. And actually, the International Club of Ascites recently changed their definition of hepatorenal syndrome. It used to be type 1 or type 2 based on chronicity and the rate of GFR decline. And I think now it's been simplified more. I don't know, Dr. Sparks, if you want to comment on that a little bit, the new nomenclature of hepatorenal syndrome.
Sure. A couple things. One, the International Club of Ascites, has no website. I think it's quite, I always like looking for, so I want to join the club,
I do too.
2007, they made their first classification, and very grateful that they changed the names because I think types 1 and types 2, we've got so many types of different things. It can be hard for a learner to kind of grasp what those were. So in 2015, they proposed new criteria, and I think there were two reasons for that. One, they wanted to synergize with the AKI definitions that had been proposed and were currently in publication for KDIGO, which is the Kidney Disease Improving Global Outcomes Guidelines. And also, I think, make it more instructive for the name nomenclature. So HRS1 became HRS AKI. And then HRS2 became one of two disease entities, mainly HRS CKD and HRS AKD, which is a little bit sort of halfway in between AKI and CKD. And I think that probably helps us in communication with teams and also with families too when we talk about this entity. And then uses the KDIGO classification of increase in creatinine urinary output that was already in place for the KDIGO guidelines, and actually made it to where HRS AKI was easier to diagnose because the threshold for a creatinine increase was just 0.3 within 48 hours, as opposed to the original definition that actually had to have a creatinine that was much higher. It was 2.5. So that was the rationale for it, and I think for me, I was all for this. The lead author of that study was Chirag Parikh, who's a nephrologist at Johns Hopkins, and I think also it was helpful for research studies to be all on the same page and to be able to classify these individuals.
Amazing discussion so far. What I would also ask is in terms of HRS, I learned that this is at the end also some kind of a diagnosis of exclusion, as far as I remember. So, what is your general workup, if, for example, in a patient with cirrhosis presenting with AKI, before you say, okay, this is HRS? So, yeah, would love to learn more about it. So, how to diagnose it, and also how the treatment is and how the prognosis is.
Yes, absolutely. So kind of what we've been doing now is what I consider my general algorithm when I'm walking through any acute kidney injury consult, not just patients with cirrhosis. You want to know what's going on systemically. Why are they in the hospital? What could be contributing to not only their general presentation, but also their acute kidney injury. The urinalysis, I mean, that's gold, right? The urine doesn't lie. You can see what's going on by examining that and by checking the urine sodium. General, that pre-renal, intrinsic, and post-renal, or however algorithm you choose to follow. I think about it as kidney perfusion pressure as my quote-unquote pre-renal. We don't have enough. Why is that? Are we hypovolemic or are we hypervolemic? Intrinsic, is there anything to suggest that there's damage happening inside the kidney itself, a glomerulonephritis, a TMA, looking at the vessels, et cetera? And then post-renal, is there an obstruction? And so that algorithm holds true even in patients with cirrhosis, because I don't have the statistics off the top of my head, but HRS is not the most common cause of AKI in patients with cirrhosis. These patients are hospitalized very often. They develop AKI very frequently, but it's not the majority of the time hepatorenal syndrome. So generally, you're still doing that pre, intra, post evaluation there. And then when you're thinking hepatorenal syndrome, and Dr. Sparks was alluding to this too, it's the volume status really, really matters, because again, it's a diagnosis of exclusion. This is a patient population it's very challenging to do an accurate volume assessment. But first and foremost, you want to make sure that they are intravascularly expanded. And so that's where the albumin challenge comes in. I'm sure a lot of people on this call have heard about the albumin challenge, have recommended it, have done it. And the goal of that is to essentially assume that we have sufficiently intravascularly expanded someone from a physical exam standpoint to then say, okay, I can, with some semblance of confidence, say this is not a hypovolemic AKI. The creatinine is not improving after your albumin challenge, which is defined as 1 gram per kilogram of albumin for 2 days. And then you say, okay, now it's time to think about treatment. And so, Jahida, I'm curious if the team was following the same thread, if they did an albumin challenge, and kind of what happened next. And I'm curious too how the sodium looks after the paracentesis and the albumin, because a lot of times we do see some pretty quick improvement there too.
Yeah, no, those are great questions. And as you're talking, I realized that there's a few other things that I didn't mention that I think would be helpful to you. So medications wise, she was on Lasix, spironolactone 100 daily. The Lasix was 40 daily, and she was on trazodone. None of those were new medications. She was not POCUS, but she did have a few other imaging exams that at least to us seemed like she was just overall just volume up. She had a CT abdomen and pelvis to rule out a PVT, and it just showed cirrhosis with worsening hypervolemia and increased ascites compared to prior studies, and chest x-ray that actually did not show any pleural fluid there, just some atelectasis. So with that, like you mentioned, so just like you were thinking, she actually did get albumin challenged. They stopped the Lasix and spironolactone. They stopped all the diuretics. And her sodium did start to uptrend, and it stabilized around 128 to 132. Creatinine, though, remained at 1.7 to 1.9, and she started having decreased urine output. Initially, it was moderate, and then she became completely oliguric. So she was started on midodrine and octreotide.
Okay, thanks. So it sounds like the team was thinking along the same lines that we are right now. And we can, first of all, breathe a little bit of a sigh of relief that her sodium is improving. We're 128 to 132. We're good. We're happy. Let's focus on the AKI. So you said oliguric, worsening GFR. They started with octreotide and midodrine. And I think this is going back to that original question of HRS treatment. What are our options? Well, octreotide, midodrine, definitely one of them. Norepinephrine plus octreotide is another. Terlipressin is another one as well. And with all three of those, plus or minus albumin. And, unfortunately, there's been no head-to-head comparison of those three treatments against each other. And so we can't definitively say that one is better, worse, or the same as the other. But I think now could be a time more than ever to maybe talk about. I guess terlipressin is kind of the newest one that's been hot off the press recently, FDA approved after the CONFIRM trial. So I know this isn't a journal club, but maybe we can start talking a little bit about the CONFIRM trial, if that's okay, just to see where we're at in terms of terlipressin. And I see Dr. Sparks is already unmuting his microphone, so I think we're ready.
Okay. Well, yeah, this is an area that, has not had a lot of data, and this is an area that we're starting to get more data, and I think it's very exciting to see that. Before I go into the confirmed trial, I do think it's important to talk about albumin. I think that because that's one of the very first steps in the algorithm, and the use of albumin in hepatorenal syndrome and cirrhosis in general is a story as old as time. The first use was in 1945 in patients with cirrhosis. And before that time, blood transfusion was a common antidote for individuals that had these low blood pressures and a phenotype of hepatorenal syndrome. And so they made a preparation of albumin that was low in sodium, which is something that you want to be cautious of in patients with cirrhosis. And giving patients, and back then it wasn't a randomized controlled trial, it was published in the journal JCI back in 1945 by Thorne et al. And what they found is that the infusion of albumin basically led to increased urine output and also improvement of peripheral edema. However, there was really no consistent effect on ascites. So ascites sometimes would get better and sometimes would not. So albumin then became fairly mainstay therapy for patients with cirrhosis. There are three indications that we typically think about using albumin. One is prevention of an entity called post-paracentesis circulatory dysfunction, or PPCD. This has actually fairly decent evidence surrounding its use. And so anytime you do a paracentesis, you should be given albumin back, and there's an algorithm for that. The second one is prevention of HRS in patients with spontaneous bacterial peritonitis. There's actually really good data surrounding that. In fact, there's a fairly decent body of literature about giving albumin in patients with infections that are not spontaneous bacterial peritonitis. Now, that is not quite as clear cut. It does seem that it diminishes other nosocomial infections. However, there runs a risk of volume overload. And we see that throughout all of the studies, including the confirmed trial, which we'll talk about in a little bit. Volume overload is something that we as clinicians need to be very on top of our minds. So we need to be watching out for that, because all of these things that we're doing to fix this physiology cannot restore it completely and often have the side effect of volume overload. If you think about the splanchnic vasculature, it's like a huge lake, especially in ascites, and it sucks up all of the volume in the entire body, not allowing it to get to vital organs like the beautiful kidney. And so we're trying to constrict that. We don't really do much, but since it's such a large volume, you can have these small improvements in the circulating effective volume, at least for short durations. And so the last thing is what we're talking about now, the differentiation and the treatment of HRS. Okay, and so we're currently already giving this individual albumin, and now we're sort of saying, okay, we think they're volume up. We've ruled out all the other parameters. The beauty about this syndrome is that it is hard to diagnose it. There is no exact biomarker. There is no way you can say exactly, okay, I looked at the urinalysis, it looks bland. We typically don't do biopsies in these patients because it's very risky. They have low platelets. They have low blood counts. They have low blood pressure. It's really, you don't want to have another problem that this patient already has and could jeopardize their ability to even get a liver transplant. So now we've made the diagnosis based on exclusion. That's also a challenging thing, is because in the back of your mind, you're always thinking, am I right? Did I do everything I needed to do to rule out every other condition? And if you feel like that is the case, and I think we're there at this case, the next treatment is vasoconstriction. And that is done with a variety of methods. We've already talked about them. The midodrine and octreotide is common to increase the vascular tone in the splanchnic vasculature, with the side effect of then increasing the effective arterial circulating volume, giving more blood flow to the kidney. We'll go ahead and just go right to the confirmed trial. Terlipressin is the drug that we're going to talk about, is a vasopressin analog, just like we used in the ICU with vasopressin. And its use has been in use in Europe for a very long time. However, the randomized controlled trials were quite small, and the FDA basically said, in order to approve this, you're going to have to do a randomized clinical trial, and hence this trial. The drug company Mallinckrodt then sort of worked with the FDA to sort of build what they would want for a trial. They have a 2-to-1 ratio of patients that had terlipressin versus placebo, so 200 to 100, and they all had confirmed, at least based on what we've talked about here, hepatorenal syndrome. Now, these patients had pretty severe hepatorenal syndrome. Yahida, what was the creatinine of our patient now?
The creatinine at this time, it was 1.7 to 1.9, so it hadn't really improved that much from presentation.
Okay, 1.7. So the average creatinine in this trial I'm talking about here was 3.5. And that's one of the critiques of this trial, is that these patients had pretty severe AKI. They also had quite a bit of albumin, up to 300 grams, before entry into the trial. And so 200 were randomized to terlipressin, 100 to placebo, and then they followed how they did over the next several days. The primary outcome was resolution of hepatorenal syndrome. And, I will just make one comment on that. We, as nephrologists, love to talk about hepatorenal syndrome. However, really, the endpoint that should be of most interest is mortality and liver transplantation. And so those are two important things to keep our eyes on. So the study then showed a reduction in hepatorenal syndrome, resolution of hepatorenal syndrome in a majority of the patients. So in this study here, they showed that 39% in the terlipressin group and 18% in the placebo group had a reduction in HRS, as defined in the creatinine level of 1.5 or less during the first 14 days. So there's a positive trial. However, it took quite a while for this to go into get FDA approval for two reasons. Mainly being that there was severe side effects of respiratory compromise. And so many of the patients had respiratory failure, 10% in the terlipressin group versus 3% placebo. Many had to have mechanical ventilation, and several died. The mortality was higher in the terlipressin group. However, it did not reach statistical significance. And there were less patients transplanted in the terlipressin group, 23% versus 29%. So after a lot of back and forth, it finally did get approval, an 8-7 vote. And now we currently have this as a therapy. Some of the benefits of terlipressin is that it can be given on the floor, as opposed to norepinephrine, which can be only given in the ICU. However, there are some studies that show that it can be successfully given on the floor. There's a nice paper out of Stanford that showed that there's a feasibility to do that, and its expense. It's about $80,000 to do this therapy with terlipressin. So yeah, that's where we currently are. What did we learn from this study? Well, I think the biggest take-home message from this study is when you use vasoconstrictors, especially terlipressin, you have to be very mindful of volume status, which I've already talked about is important in the diagnosis. But as this patient you're following them, and they're already on oxygen, then you might not want to use vasopressors, or you might want to include the addition of diuretics. And there's a nice paper also from Juan Carlos Velez, who's really into this topic, just published in Kidney International, that showed that the use of diuretics concomitantly with norepinephrine resulted in improved urine output and could have diminished the volume overload that we see in these patients. So I'll stop here and we can have a discussion about this.
Thank you so much for this brilliant discussion so far. There is one question in the chat regarding the use of diuretics, or whether you could speak to the diuretic choice approach, PO versus IV, in patients with cirrhosis and volume overload, and also outside of AKI concern for HRS.
I'll let Ali take this one.
Sure. I mean, I think that's going to be very patient dependent, right? If someone's coming in with cirrhosis and they're volume overloaded, and they're in the hospital, I usually go immediately to IV diuretics, especially if we're concerned about the respiratory status, specifically pulmonary edema. A lot of these patients come in on combined Lasix and spironolactone, a combination that's frequently used for mitigating ascites accumulation buildup and trying to maintain adequate electrolyte balance. And so I usually use the Lasix dose as a guiding point for what kind of IV dose to give when I'm trying to diurese these patients. We know that the fluid shifts, it's not necessarily a diuretic that is nephrotoxin, it's fluid shifts that could cause bumps in creatinine. And so again, it's a day-by-day decision. What is the immediate problem here? Is it pulmonary edema leading to respiratory decompensation? We need to diurese aggressively. I will diurese aggressively. I will try to get fluid shifts off. We'll worry about the creatinine afterwards. We're monitoring urine output more than anything else. Conversely, in the patients who come in with cirrhosis and AKI and you're wondering about hepatorenal syndrome, you've done your assessment, whether it includes physical exam plus minus POCUS, you think that they are euvolemic, there's a potential possibility that they're intravascularly hypovolemic. Those are the patients that you classically, when you give that albumin challenge, you're also holding diuretics. And so it's not a one-size-fits-all approach to these patients. You need to be really, really careful. I hope that addresses the question.
I think that's perfectly. And another question is because there was a very nice question about the albumin challenge. So just to clarify for the listeners out there, so what are you looking for if you do this albumin challenge?
Yep. So the role for the albumin challenge specifically in the diagnosis of hepatorenal syndrome is to see whether or not intravascular volume expansion with albumin, 1 gram per kilogram over 2 days, results in an improvement in the creatinine. If it does, you can think, okay, there's probably more of a volume issue, an intravascular issue, and unlikely to be hepatorenal syndrome alone. Other contingencies that you want to look at is, you want to make sure that you're not worsening the volume status the opposite direction. You don't want to cause hypervolemia, pulmonary edema. So just monitor that daily and monitor the sodium as well. But the whole point of the albumin challenge is to try to reintroduce intravascular volume and see whether or not that is enough to improve the GFR.
Thank you so much. Then I would give the mic to Jahida for how the case evolved, and also would like to ask you both what you think, what would you do at this point management-wise, and what would you consider,
yeah, I'm curious to see if the midodrine octreotide did it or what can and came next.
Yeah, it's honestly very interesting to hear Dr. Sparks talk about the assessment of fluid status on these patients. So interestingly enough, this patient, like I said, continued to have creatinine rise on the midodrine and octreotide. She was switched to terlipressin. The creatinine continued to stay at around 2.3. She became oliguric and needed to be started on a Lasix drip. And eventually, she went back to room air. Her creatinine improved, and she was discharged with a creatinine of 1.8 to 1.9. And to the discussion of liver transplantation, she was not deemed an inpatient liver transplant candidate because she had a positive PEth about a month prior to admission. So they did not want to consider her for transplantation then. Since then, though, she has been seen by GI in the outpatient setting. She's had 3 months of sobriety and has had negative PEth since, and she is going to be considered for liver transplantation. Her creatinine has improved, and I believe her last creatinine was 1.5. So not at her normal, but it's a lot better than when she came into the hospital, and her sodium was 128.
Oh, interesting. So they switched her from midodrine octreotide to terlipressin, and then she developed exactly the adverse effect that we are most concerned for, which is respiratory failure. I'm glad she responded to diuretics, and I'm happy to hear that she will likely be a liver transplant candidate in the future. I think a question, if it's okay, and it sounds like maybe it didn't come up in this case because she did respond to diuretics, but a question that comes up not infrequently is in these patients who maybe don't immediately qualify for liver transplant, they have worsening oliguria, maybe develop anuria, become, uremic or have respiratory failure. The question of dialysis comes up. And, I think when it comes up in someone who is qualifying for a liver transplant, especially inpatient, we say, okay, dialysis, we're going to try this. It's going to be a bridge to transplant. But in patients where transplant is either uncertain or the answer is no, and I'll probably defer to Dr. Sparks on this since I'm 5 months into my fellowship and haven't run into this very frequently yet, but I imagine that's a really challenging conversation. There's a lot of risks and benefits to weigh about whether or not you ultimately offer dialysis. I'm sure it becomes a really big conversation about goals, but Dr. Sparks, what's been your experience with that?
Yeah, and this is a challenging consult and situation that we're often in as nephrologists. I think as nephrologists, we need to lead in this discussion. One is an opportunity for us to have a discussion about end of life and goals of care with the patient and their family. I think that's really important. Regardless of what the transplant and where currently are, it's clear that this individual has multi-system organ failure and a high mortality because of all of these conditions. So I think it's really important to do that. There are situations where dialysis at the end of life is appropriate. For instance, family members that are coming in from uh, far away that want to see their loved one for the last time. I think under direction from the nephrology team, the patient, and the primary team, that's a possibility. Doing a dialysis in someone with cirrhosis is incredibly difficult. Oftentimes, the blood pressure is just not high enough to be able to do successful dialysis. It often will mean they'll never leave the hospital. And so these are the important things that need to be discussed with the patient and the family. That it's not just hooking them up to the machine and then sending them home. This is going to be something that means that you likely won't leave the hospital, and oftentimes you won't leave the intensive care unit. You might need continuous renal replacement therapy. So this is a very serious situation that has to have a nuanced discussion with the patient and or their surrogate when the time comes. And that's why it's important to start bringing these up very early in the conversation because you're not 100% clear, which way it's going to go. And I'll go back again to the confirmed trial. The great thing about clinical research is that we able to understand the disease process in a very detailed manner. And so in the confirmed trial at day 90, about 40% of the patients in placebo group had dialysis and about 29% in the terlipressin group. That's pretty high numbers. So a third of the patients ended up needing some form of dialysis. And that's why it's important when we first see these consults to bring up dialysis so it doesn't become something that just pops up at 2 o'clock in the morning when they're transferred to the ICU.
Wow, so many brilliant teaching points in just 40 minutes. I would be curious, Jahida, how did this case evolve?
Yeah, so ultimately, she was switched to terlipressin. She developed pulmonary edema, and because she was already oliguric, she required some diuresis, needed a Lasix drip in order to have her urine output increase. She did discharge on room air, but her creatinine was elevated compared to her baseline. So she's just been followed up by hepatology in the outpatient setting and needed to have some discussions about sobriety in the outpatient setting with social work and her hepatologist, and now she is listed for transplant.
Amazing. And Dr. Tomasi, Dr. Sparks, do you have any reflections so far?
If I can address, I see a comment in the chat that someone asked about liver kidney transplants, and that is a whole conversation for like another entire hour. But since I just rotated off of that service, I'll speak to it a little bit. There's a lot of very specific criteria that patients need to meet in order to get a kidney transplant, including in the context of also receiving a liver transplant. And those include, there's either a chronic kidney dysfunction criteria or an acute kidney dysfunction criteria. And there's a set GFR, dialysis dependence, and chronicity to both of those. And if patients meet criteria for liver transplant and meet the criteria for kidney, they can get a simultaneous liver kidney. Now, in the case of hepatorenal syndrome, it's really interesting. And I saw Mike Turk, one of my co-fellows, responded to this chat. So I want to emphasize that. Sometimes, in these acute hepatorenal syndrome cases, if you get the liver transplant, the kidney function is going to improve. They haven't had damage for a chronicity and level of chronicity that leads to more of a permanent dysfunction. And so it's not always the case that when someone develops HRS, they will also be considered for liver kidney. It's going to depend on the criteria for kidney transplant as well.
Amazing. And Dr. Sparks, do you have any final reflections on this case so far?
I think we have covered a lot of ground here, and this is a topic that comes up very frequently. And the good news is we have more and more therapies that I think we're using, and we're getting more sort of thoughtful about our approach to it. And I think that's because of research that's happening in the area. I'm also very intrigued by the use of point-of-care ultrasound, which I think is a very important tool that we in nephrology are really pushing. And I see Mike Turk, who's on in the chat, has been really instrumental here at Duke in that regard. So I think that's a very key aspect. The last part is I do think we need better biomarkers, and those are coming. For instance, urinary INGAL is a potential urinary biomarker that could help in the diagnosis of this condition. The other is CXCR9 for AIN, which we commonly see with the medications that we're giving to these individuals. And I think then we need to have a more thoughtful approach about how we use vasoconstrictors in the hospitals. And I think terlipressin has reinvigorated that area. But we do have a lot of other therapies that we can use. And I think, putting people in the ICU versus the floor, we maybe need to have a cirrhosis unit where we can deploy these therapies and not have to think about transferring a patient to a whole another floor in order just to do like a norepinephrine infusion, for instance. So I'm really excited about the future, and I think we're having a lot of great discussions surrounding this. And it's also important because very multidisciplinary care. I'll point to the users to some good resources. One is the Liver Fellow Network. They have some great papers that kind of go into depth on this. So check that out. and also things like what we're doing here with the clinical problem solvers.
Wow, that was just so impressive. I would be curious, Jahida, what you learned from this case so far.
Yeah, so I think in general, whenever you have a patient with cirrhosis and you're working them up initially and you have that creatinine and sodium, patients with cirrhosis have such complicated physiology and there's so many factors that can be going on. And I think just like Ali mentioned, just taking a step back and just learning and knowing those very classic pre-renal, intrinsic, and post-renal workup of an AKI, and know that HRS, even though we as internists think of HRS right away whenever we see a cirrhotic patient with an AKI, just know that that's a diagnosis of exclusion, and just go through that entire workup like we did right now and just rule out, are they bleeding, go through the vibes mnemonic, go through, your just your UA workup, get a bladder scan, all of those things. And then when all of those come back completely normal, talk to your friendly nephrologist and figure out, what other therapies are there out there so that you can help the patient improve.
Thank you so much for this educational case. And before ending the session, I would ask Dr. Tomasi and Dr. Sparks whether both of you would like to share your free final teaching points on this case or on HRS. So what would you want the listeners out there to hear before we end the session?
Sure. I love what Jahida just mentioned about, essentially anchoring is, I think, the thief of a good diagnosis from the beginning. You just need to be thinking about all the things. And I think that's what we in internal medicine, have the privilege of doing each and every day with every single patient case. I think for me, the teaching point is always think about the underlying physiology, because if you understand what is going on a physiologic level in the patient in front of you, everything starts to align and make sense. And there's so many excellent resources out there that, if you don't quite remember the physiology of hepatorenal syndrome, look it up. I go back to the same review every single time by Dr. Simonetto at Mayo Clinic on hepatorenal syndrome. It was published in the BMJ. They have like a beautiful graphic in there. And I always go back to that and remind myself. And I think that can be done in really any case, that definitely one that involves the kidney, but in internal medicine, just go back to the basics, go back to the physiology and find a physiologic state that explains what you're finding on labs and exam, and you can't go wrong.
Amazing.
I think, for me, I want to just go back to the volume status, both in the diagnosis and then when you're treating the patient for hepatorenal syndrome. I think that's really important and oftentimes is missed. And, you can see a randomized clinical trial where probably those patients, could have been identified as becoming more volume overload and really acted upon earlier. So I think in that regard, what I want to say is that we as physicians can be stubborn and oftentimes look at our physical exam and will not change our minds. I think I want everyone to be more open-minded about their volume status assessment and think about, how can we improve it? What can we do to ensure that we're really truly making the correct diagnosis? I think in a disease like hepatorenal syndrome, really that's the linchpin of the diagnosis, and two, helps prevent morbidity and mortality, and also prevents them from getting liver transplants, as we saw what happened in that randomized clinical trial.
Thank you so much, Jahida, Dr. Sparks, Dr. Tomasi. I've learned so much in just 1 hour, and especially with HRS being so complex, just having the privilege to get an insight to this. So really, thank you so much for taking your time. So I would then end the session here. And yes, so thank you so much for being here. And I hope you all enjoy the rest of your day and hope to see you all again soon. Bye, everyone.
Thank you for having us.
Thanks for having
Bye,
us.
thank you.
Bye.